Good afternoon. Welcome to the Assembly Committee on Health and Human Services. Secretary, will you please call roll?
Assembly members Dahlia. Here. Edgeworth. Here. Gonzalez. Here. Goulding. Here. Gray. Hafen. Hibbets. Here. Hunt. Here. Jackson. Here. Koenig. Here. Nadim. Wen. Here. Orntlicker. Here. Chair Brown-May.
And I am here. Thank you. Please mark Assembly members Gray and Hafen present when they arrive. Okay, welcome to our audience here in Carson City. What a great look in this room today. Also to our audience in Las Vegas and to those of you who are joining us online. A couple of housekeeping items as we get started today. Please silence your electronic devices. If you wish to testify, please sign in at the table by the door and provide a business card to the committee secretary. When testifying, please turn the microphone on and clearly state your name and affiliation, if any, for the record. Then turn off the microphone each time you are done speaking. Electronic copies should have been submitted to our committee manager by 12 noon yesterday for members. We have a presentation. Anyone supplying hard copies, 10 should be provided for the public. Members of the public may provide public testimony on a bill either in person or by telephone. To do so, you would dial 888-475-4499 and then when prompted, provide the meeting ID, which is 850-4564-0150 and press pound when prompted for a participant ID. Meeting agenda and committee information is available on Nellis, which can be accessed through the legislature's website. You may also watch our meetings through Nellis or on the legislature's YouTube channel. Public comment will be taken at the end of our meeting today. Each person will be limited to 2 minutes. Please note we expect courtesy and respect in all of our interactions during this meeting, even if we may not agree with another person's position. Also note, committee members will be using their laptops to view handouts and other documents. Please don't view this as a sign of disrespect or inattention. They are working very diligently. Okay, with that, we will open our meeting today with our first agenda item, which is an overview of the Aging and Disability Services Division, the Division of Child and Family Services, Department of Health and Human Services. You can take the table and begin whenever you are ready. Welcome to Administrator Dina Schmidt and Administrator Marla McDade-Williams. Thank you.
Good afternoon, Chair, Vice Chair, and members of the committee. My name is Dina Schmidt. I serve as the Administrator for Aging and Disability Services, and we are here today to give you a high-level overview of our division as well as Child and Family Services. On the first slide is the agenda. The things we'll be going over is just a brief overview as well as our mission and our priorities. And then afterwards, we'll both wrap up with a discussion about other work done by our divisions. Aging and Disability Services is made up of several programs, each dedicated to ensuring that people feel supported through every stage of life and circumstances. Our services are really aimed at supporting individuals and their caregivers and family members to ensure that they have the ability to live at home for as long as they want in an integrated environment. So on page 4, slide 4 is our organization chart, and I'll just spend a minute here talking about some of the programs that we provide for the new members. So obviously we have our administration programs. We start with children's services. So Autism Treatment Assistance Program provides services to children diagnosed with autism. We provide the financial support to the families to receive services known as ABA or Applied Behavioral Analysis. In our early intervention program, we provide services to children 0 to 3 who are born or have developmental or delays or disabilities. Those services can include anything from OT to PT, speech, hearing services, as well as special instruction. We are in Nevada. We have a model where the state is a provider, a comprehensive provider, and we have several community providers, so contracted organizations in the community that also provide the same service. We also have the long-term care ombudsman program. Our ombudsmen go into skilled nursing facilities, group homes, any group setting to advocate and ensure the rights of the residents. So they do this through a normal, regular visit throughout the year. They also act on complaints. So they go out and investigate complaints, work with the facility management, the individual to make sure that their rights are being upheld and that they're receiving the care that they need. In our developmental services programs, we operate these through 3 regional centers. So these are services to individuals with intellectual and developmental disabilities, and it's an array of services, anything from respite to jobs and day training, supported living arrangements, a variety of services to support the most integrated living environment possible for individuals with intellectual and developmental disabilities. We also operate a 24-hour intermediate care facility known as our DRC ICF. And that has 39 residents currently who live there 24/7 and are supported by our staff. We also run a quality assurance programs across all of our programs. One of the exciting things we've done over the last few sessions is build out our quality assurance team, just to make sure that we have quality assurance measures, processes, and procedures in place for every one of our programs. We used to only do the quality assurance for those programs mandated, but we now do it for all programs, whether it's mandated by federal regulations or not. We also have the Office for Consumer Health Assistance. This unit is really a group of ombudsmen who can help you navigate your healthcare, any healthcare access issue you may have. So it's really making sure that people understand their rights under their healthcare policies. So individuals, when you get your bill from the hospital, it has their phone number on the bottom. If you're having questions about your bill, if you're having questions with prior authorization, enrollment, eligibility, any of those types of things. And this program does serve all Nevadans across all populations. We also have the Adult Protective Service programs. This program really supports individuals through preventing abuse, neglect, exploitation of vulnerable adults as well as seniors. They go out and investigate complaints and try to alleviate any issues that may be at hand and address the current crisis and make sure that individual is safe while also respecting their civil rights to live as independently as they choose. That program, I do just want to, is not law enforcement. We work and collaborate with law enforcement. If there is a critical or criminal element that we find, we refer to law enforcement for that portion of the investigation. In our Office of Community Living, we operate 2 Medicaid home and community-based waivers, the frail, elderly, and physically disabled waivers. These programs provide in-home services to seniors as well as people with physical disabilities. It's a variety of different services, anywhere from home care, respite, shopping, assistance with activities of daily living, such as bathing, grooming, dressing, all aimed at really keeping people out of institutions and remaining in their home for as long as possible. That program also, in that Office of Community Living, we also have our Communication Access Program, as well as our Facility Outreach and Community Integration Program. One of those programs is really focused on trying to help families or individuals living in facilities move into the community. So we can help with one-time costs as well as wraparound services to ensure that somebody who's wishing to move out of a skilled nursing facility or other institutional setting into their home, that we can be there to support that. We also have our grant management team, community grant programs, where we fund community organizations through Older Americans Act, approximately $28 million in Older American Act funds for a variety of services, anything from congregate meals, home delivered meals, respite, caregiver supports, transportation, a variety of services also aimed at keeping seniors in their home and in their community. And we also have our legal advocacy team, which is really just made up of our chief advocacy attorney, who is also our legal assistance developer and oversees our grant-funded programs in the community that provide legal services to individuals, seniors in the community. Moving on, this next slide, we just thought we would organize it this way. Sometimes people wonder why aging and disability services were put together. And this gives you that picture where some of our programs only serve children, some serve adults, and some serve seniors. But you can see here, the majority of them either serve both populations or all 3 populations. Moving on to the next slide is really just want to give you an overview of some of our legislative priorities. Last session, we had several rate increases that really helped our providers build capacity to serve more people. We had this in our developmental services programs as well as our community options programs, which are some of those in-home programs for people with physical disabilities as well as seniors. So really trying to make sure that those rate increases continue. We have seen an increased utilization of those services, so which is a great thing. So we know people are needing the services and getting the services. We're also looking at creating a standardized assessment for developmental services. This allows us to have a team that's independent from our program, make the assessment of needs, and then refer out to providers. We're also looking at epidemiologists to really help us wrap our heads around the impact of opioids on the populations that we serve, both children as well as adults and seniors. These epidemiologists are really, we're trying to look at how can we look at the impact and understand the impact of opioids and other health conditions or substances as well. And how do we integrate that into our service array and in order to help alleviate some of the negative impacts of substance abuses. You'll hear later today more about AB6, so I won't go into that. And then the transition of Part C to our organization is our last one. And lastly, I just wanted to talk about a couple. I know that this committee heard last Friday presentations from my sister divisions regarding behavioral health. So I wanted to follow up with some projects that we have going on right now that complement those programs, just to get an understanding of how we're trying to tie our service delivery to the other sister agencies. So we, through ARPA funding, have several capacity building projects that we are starting this year. We have the 2 years to spend the money and complete these projects. The first is really a capacity building institute. All these projects are focused on individuals with intellectual and developmental disabilities. So the Capacity Building Institute really is focused on increasing capacity among Nevada's current system to support individuals with IDD and complex needs in the community. This model was developed in Pennsylvania and it's currently being replicated across several states. A couple things just to keep in mind, it's a 9 two-day sessions over the period of 8 months, and participants are separated out into small groups, and they get to discuss and apply learning as well as didactic and large group work. So these are really focused on actual cases, difficult to serve individuals with behavioral health providers across the state, not just in our organization, but community providers, public and behavioral health, child and family service providers, trying to build the capacity to work with our populations. And so at the end of that project, we anticipate approximately 60 participants per session, like I say, across all of those behavioral health units. So we're hopeful that will really help grow the capacity to serve folks in our state. The second one is our training library. This same organization is focused on creating training libraries to targeted audience that includes information anywhere from case management to behavioral health, child welfare, family support programs, juvenile justice. Those are really the target audience. And then the topics will include reducing critical incidents, behavior escalation, mental health crisis, risk reduction without rights reduction, trauma-informed care and stress disorders in people with IDD, positive behavior supports, and a whole array of services and topics, but that we really anticipate being helpful to providers who may or may not have worked with individuals with intellectual and developmental disabilities, but this would be available at their fingertips to try to look up something and get a little bit more information on the best practices. Next is our National Association of Dual Diagnosis Technical Assistants. This is an organization that developed technical assistance and training plans to support our providers in achieving certification and accreditation in working with individuals with IDD. And then there's a Juvenile Justice Learning Collaborative. We are working with our partners at DCFS and our local juvenile justice staff to design and implement an in-person learning collaborative that will facilitate peer-to-peer learning among juvenile justice, child welfare, and developmental disability state and provider staff. Really, the hope here is to create a space where we can work together to address the critical needs of children with IDD. As you've all heard, that has become an ongoing challenge for all of us. And lastly, there's a peer provider technical assistance. This is a sub-grant with a national known provider whose best practices to support direct, intensive one-on-one peer training and technical assistance to our Nevada providers. At the end of this project, we anticipate serving 140 to 150 people identified by our regional centers. So this would be up to 150 individual cases of our most extreme and difficult to serve individuals, working with their providers on a one-to-one peer-to-peer training on how best to support that individual. And really, if some of those, it's also on, looking at transitions. It could be transitional care out of our intermediate care facility and into a home and community-based setting. It could be looking at individuals who are currently placed out of state and bringing them back into state, working with those providers and giving them that training and one-on-one peer support. So we're really excited about that opportunity to support and grow the capacity for our provider network. And with that, I'm happy to take any questions on my portion, or if you would, if it's your preference, Madam Chair, we can move on to Child and Family Services first.
Thank you. If you don't mind, let's do the whole of the presentation, and then we'll take questions from committee.
Thank you, Chair Brown May and members of the committee. For the record, Marla McDade Williams. I serve as the administrator for the Division of Child and Family Services. So y'all heard from me earlier last week. And so what today I wanted to focus on, as you know, we do have children's mental health services, outpatient and inpatient services. Today I wanted to focus on one of our inpatient services, which is an overview of Desert Willow Treatment Center, which is it's licensed as a children's psychiatric hospital, and we take commitments from the community, including the child welfare system, the juvenile justice system, and families. We serve youth with severe emotional disturbances, youth that are acute, and or that meet residential treatment center level of care recommendations, youth who can't effectively respond to services provided in a least restrictive setting, youth meeting medical necessity and admission criteria as defined by Medicaid Services Manual for Chapter 400, and then uninsured youth requiring an inpatient level of care. And as discussed last week, one of our focuses is ensuring that applied behavioral analysis treatment is available for youth who are treated in Desert Willow. We provide psychiatric services that are evaluation, treatment, and medication management, psychotherapy to individuals, family, and group. We also have dietary needs, pediatric services, therapeutic recreational activities, and then, of course, ABA. So we do have limited capacity at Desert Willow Treatment Center. We have 54 beds in the facility. We currently have 44 available and due to construction in one of our wings. We have 24 beds that serve as a psychiatric residential treatment facility, serving youth, I think primarily 12 to 17 years of age, 8 beds for pediatric patients, and then 12 acute beds. The psychiatric residential treatment facility beds are almost always full, and we have the highest demand for those services. Youth present to us with multiple challenges from the court systems. Youth in the juvenile justice system need treatment. They are not suitable for care in a state juvenile justice facility because of their treatment needs. They present challenges beyond their behavioral and mental health needs, and our staffing needs to ensure that we can maintain a level of control of these youth. Youth with other very high needs often fail out of private placements, and Desert Willow Treatment Center becomes the last opportunity for them to receive care. Programming needs to ensure we can meet their needs, and Desert Willow Treatment Center must constantly adapt to meet those needs. So here's just a list of the services that are in the Desert Willow service delivery system: trauma-focused cognitive behavioral therapy, dialectical behavioral therapy, motivational interviewing, psychiatric evaluation and treatment, medication management, psychiatric nursing services, psychological assessment, therapeutic and behavioral modification, and you can see the rest: social and skills training, psychoeducational services, and psychiatric oversight. To be admitted to Desert Willow, generally they come to us by way of referral, but those referrals are coming from the child welfare agencies, the juvenile justice system, psychiatric hospitals, other facilities, community partners, and a lot of court-ordered placements that we are looking at having to manage. All referrals are reviewed by the Desert Willow Treatment Center Residential Admissions Committee to determine if the patient meets the diagnostic criteria for a residential admission. And so that Residential Admissions Committee consists of the Desert Willow Treatment Center Medical Director, an attending psychiatrist, a senior psychologist, a clinical program manager, and a pediatric physician as necessary. We have about 30 to 120 days for youth to be admitted to the facility, and again, focusing on their psychiatric concerns and conditions as well as behavioral concerns. We also use something called positive behavioral intervention and supports in the facility. We do have family and guardian engagement, and then discharge planning becomes a huge part of what needs to happen when we're looking for continued services for youth beyond their treatment at Desert Willow, and ensuring that there's an adequate continuum of care available to them. On our acute admissions side, they are generally coming from hospital emergency rooms and emergency departments, the mobile crisis response team, and again, juvenile justice programs, and some of our facilities, Summit View Youth Center, Nevada Youth Training Center, Caliente, John Evans, Washoe County Juvenile Services, Clark County Juvenile Detention, and the Department of Family Services in Clark County. So in the acute program, it really is short-term stays that we're looking at, 3 to 7 days, although some youth are in there longer. We do try to stabilize and reduce symptoms and prepare the youth and family for either reunification back at home or to ensure continuum of care services are scheduled prior to discharge. In the acute program, we focus on uninsured youth, referrals primarily from mobile crisis and or emergency departments and emergency rooms. In terms of admission, once they're accepted, a psychiatric caseworker prepares their admission documentation, and then they also compile a list of participants that in the patient's care that will participate in weekly team meetings. When we're ready for discharge, again, it depends on high quality discharge planning and activity as well as family involvement. It does signify the completion of treatment at Desert Willow and is the release of a patient from inpatient psychiatric care back to home or a lower level of care in the community, sometimes a group home or a foster care setting, depending on who has custody of that youth. Understanding the patient's planned placement at discharge ensures that there are appropriate supports and a continuum of care post-discharge. Discharge planning is discussed at the patient's weekly team meetings as well. Some of the considerations when undergoing discharge planning are patient and or family choice, the level of care recommended post-discharge, patient placement at discharge, availability of resources, engagement of resources, as well as identification of other treatment that's necessary after discharge. So that's just a quick overview of Desert Willow. And again, we do have the Psychiatric Residential Treatment Facility North in Reno that also admits youth, a much smaller scale and different needs than what we're looking at Desert Willow. And that concludes my presentation, and we're open for questions.
Thank you, administrators, for the presentation and the information. Members, does anyone have questions? Okay, I do have a couple. Thank you for your presentation. Let's start with the Aging and Disability Services Division. First of all, thank you for that slide, programs by population. I believe it's slide number 5, which really, I think, breaks down where youth are served, adults are served, and seniors are served. So thank you for that. I'm curious to know, though, are the provider organizations that are contracting with the Division of Aging and Disability Services, is it common for a provider to serve all 3 age groups, or is it more specialty services for each one of those groups?
Dina Schmidt for the record. Thank you for that question. So it depends, I would say, by the program. Normally in, like, let's just take developmental services as our first example. We don't, supported living arrangements and jobs and day training are not services that are usually appropriate for children, but we do have, we've had a couple who have piloted working with children and the child welfare system and had some successes there. We also work with, they also work with children who are maybe transitioning into adulthood and coming into those services prior to their 18th birthday. So it just really depends on the program. I think in independent living services, right, that's a different story. They serve in person with a physical disability regardless of age. Individuals who might be on our physical disabilities waiver, as they age, they have to make a choice between the PD waiver and the FE waiver. And so the service array in those 2 waivers are different. So most folks can figure out what services best fit their needs. But the providers in the waivers are generally the same providers across those waivers.
Thank you for that clarification. I appreciate that. I have a question from Assemblymember Goulding.
Thank you, Chair. You mentioned that there's a facility in the north that is smaller and provides different services for different kinds of needs. So do you transport folks from the north to the south when they need services that are provided in the south? Can you unpack that a little bit about serving folks from the north and the south separately?
Thank you. For the record, Marla McDade Williams. Chair Brown May, if I may respond to Assemblymember Goulding.
You may go direct. Thank you.
Thank you. There can be transport. Primarily, our facility in the north does serve northern Nevada. But if there is a need, a psychiatric need that can't be treated there, we would work with the agency that is wanting to have that need at Desert Willow. We would work on transporting them to Desert Willow Treatment Center for psychiatric inpatient treatment. But yes, we would work with any organization depending on, again, the needs of the child. Our facility in Washoe County serves a lot of youth out of the Washoe County juvenile justice system as well as a child welfare system from Washoe County.
Thank you. Next, we have Assemblymember Jackson.
Thank you, Chair. This is for the Department of Aging. I'm not sure if this already exists or if there's any plans of this. Is there any aging facility for the Department of Corrections for their elderly population that are receiving parole?
Dina Schmidt, for the record, that's a great question that I do not know the answer to. I don't know if there's any skilled nursing facilities in our state that, provide services to that particular population that I'm aware of.
Thank you. Any other questions, members? Okay, one more from me if you don't mind. Do you have a count, Administrator Schmidt, of the number of youth that would potentially access services that you've identified throughout the course of your presentation? Do we know what the need is, and are we meeting the need?
Dina Schmidt, for the record. So could I get some clarification on the youth that would access all of our services?
Thank you for that clarity. So I guess my question really is about, do we have capacity in our provider network? Are we able to meet the needs of our students, perhaps that are transitioning into different types of needs? Are we able to meet the adults in our population? Is there a waiting list for services? Do we need more providers? What's our capacity?
Dina Schmidt, for the record, thank you for that clarification. So currently we definitely have wait lists across all of our services, and I think our capacity building projects are an example of why we aren't meeting that need, because especially with youth with autism and other neurodevelopmental diagnoses, I think we're really seeing a struggle between the mental health providers being able to support those individuals, and so that is one of the reasons we're really focused on this capacity building, is so that people can work with individuals who are dual diagnosed, right? If an individual has a developmental disability, that doesn't mean they don't have mental health needs, and that they can't benefit from the same mental health modalities that everybody else does. So it's really, we're focused on that area for behavioral health needs of individuals that we serve. When it comes to our other programs, our autism program, I always like to give a shout out to that group. We've really reversed. When I first got here, I think our wait list was in the 900s and we were serving maybe a couple hundred. Right now we're serving over 1,000 and we have a wait list of only 87. So we've really been able to make a dent there. And so we do have wait list in our frail elderly, physically disabled, and in an IDD waiver, all three. We also have wait lists for our JDT and SLA services, as well as our personal care assistance program and our community options program for the seniors. Those are the programs that mirror the waivers and support people in their homes. So we do have wait lists for all of those programs.
Thank you for that. Assemblymember Ohrenlichter.
Yeah, thank you, Chair. Thank you for the presentation. And my question's about admissions to Desert Willow. And is eligibility affected by insurance status? That is, if people have good private insurance, are they still eligible, or how does that work?
For the record, Marla McDade Williams. I'm going to get to call on Dr. Jacqueline Wade down in Las Vegas to kind of talk through that issue. We do take private insurance as well, but I will have her address that issue. Thank you.
Good afternoon, Chair and committee members. Dr. Jacqueline Wade for the record. Thank you for the question. Admission to Desert Willow, we do have the families that are uninsured, underinsured, and those families that have an exclusion for psychiatric residential treatment programming on their insurance. So for the majority of the kids, they are uninsured or underinsured when they accepted into the facility.
Assemblymember Nadeem?
Thank you, Madam Chair. Thank you for the presentation. My question is that, as you mentioned, that there are 44 beds available right now. So is there any time frame when all the beds will be available for the patients?
For the record, Marla McDade Williams. I believe our time frame is now December 2026 for all of the construction to be completed. We've run into an issue with the contractor that was on board, and so we had to go out and get a new contractor, so it is extending the time. If I've misspoken, Dr. Wade will correct me.
Thank you.
Okay, it appears
Dr.
as...
Wade for the record.
Go ahead,
You're
Dr.
correct.
Wade. Thank you for that clarification. So, Administrator McDade-Williams, if you don't mind, I'll follow up with one more question. Could you speak a little bit about what part of services the state is responsible to provide? And then what part of services are we partnering with county or local municipality to deliver services? And how are we meeting the needs? Is there a wait list for youth services?
For the record, Marla McDade Williams. So statutorily, we are required to provide child welfare, child protective services, foster care, and adoption for the rural counties. Clark County and Washoe County are responsible for child protective services, foster care, and adoption in their respective counties. And then we are also statutorily required to meet the juvenile justice services needs. Counties have a certain level of responsibility, and then at the point that a youth is adjudicated into our system, then we have the responsibility for the facility care. For children's mental health, we are authorized to stand up and have residential facilities, so Psychiatric Residential Treatment Facility North, Desert Willow Treatment Center. Those are entities that we are authorized to have. We are authorized to provide children's mental health services. There is no clear mandate that we provide any level of children's mental health services. But what we do is we try to ensure that we are meeting gaps in the community. For example, child welfare services and foster care, the counties license all the way up to specialized foster care facilities. At the point that we are unable to find placements in private facilities for youth that exceed that level of care in a specialized foster care, we work collaboratively to, again, see if we can admit them to the facilities that we have. Or in some cases, we are mandated by the courts to help find placements for those youth. The entities that are not mandated to accept anybody in the state are the private facilities. So we work with them as closely as we can, but they are not required to keep any youth. If a youth becomes a behavioral problem, we aren't required to keep a youth for that matter either. But we do everything we can to keep youth in our care once we have them, because we know that there are no other placements for them, and they're going to fail out of other placements. So one of the things that I have been trying to do since I have been the administrator is ensure that we have all of the services that they need, that I staff up to the needs of the youth so that we can keep them here. But the biggest part of all of the system is that continuum of care and step down once they leave our facilities. We are not a permanent residential placement for any youth at all. That is not our role in any of the facilities that we have, unlike ADSD, which has an intermediate care facility that would keep someone 24/7 long-term. We don't have any of those facilities under the Division of Child and Family Services. So our role with the Children's Mental Health System has to be very collaborative with all of the organizations that have needs. We are trying to meet them together as much as we can. And again, reprogramming for the resources that I do have, I want to ensure that we're just meeting needs, that we're filling gaps that are out there in the community. On the residential side, though, we have struggled because of staffing. You know, we don't compete with the private sector when it comes to nurses, so I can't staff up with nurses as much as we probably could. You know, in other facility types as well. You know, when we are locked into the state classification system, it makes it really hard for us sometimes to staff up to what the actual need would be in any facility. I don't know if I answered your question or not, but.
Thank you. But just one last follow-up then. You did answer a big portion of my question. Do we have a number of youth that are requiring services that we're not currently able to meet the needs for? Are there kids waiting for services that we're aware of?
For the record, Marta McDade Williams, I mean, we do have a small waiting list in Desert Willow, but there are always kids out there who would benefit from a different level of placement. There's no active waiting list for them. I think you've heard me talk about this before, and at the risk of opening up a can of worms, Clark County Child Welfare System, if they don't have placements for someone, they're staying in Child Haven up until the point that they can find a placement for them. But those youth are in their custody. They are child welfare kids in custody of Clark County. But again, we're all working together to try to find placements for them if it goes beyond a specialized foster care placement.
Thank you for that clarification. Members, any other questions? Okay, seeing none, thank you so much for your presentation today. Okay, we will now move on to our next agenda item, and I will open the hearing on Assembly Bill Number 6, which establishes the Fetal Alcohol Spectrum Disorder Treatment Assistance Program within the Aging and Disability Services Division of the Department of Health and Human Services. You may begin when you are ready.
Good afternoon, Chair Brown-May. Thought I was going to mess it up. Sorry, every time. Good afternoon, Chair Brown-May and members of the Assembly Health and Human Services. I would like to thank you for the opportunity to introduce AB 6 to all of you today. My name is Ricky Robb, Deputy Administrator for Aging and Disability Services, and I'm joined today with Samantha Jaime, our Health Program Manager for the Autism Treatment Assistance Program. I will walk you through the specific highlights of the bill. In addition, I will be happy to answer any questions of the committee during or after the testimony. AB 6, Assembly Bill 6, establishes the Fetal Alcohol Spectrum Disorder Treatment Assistance Program within Aging and Disability Services Division of the Department of Health and Human Services. The intent of the Assembly Bill 6 is to provide the department with the ability to provide and coordinate the provisions of services to persons diagnosed or determined to have fetal alcohol spectrum disorder through the age of 13. I'd also like to say it's also known as FASD. In the 2023 legislative session, AB 422 required the division to create a pilot program for individuals with fetal alcohol spectrum disorder to be administered by the Autism Treatment Assistance Program, known as ATAP. During the pilot program, the ATAP program worked with the Families Moving Forward program through the Florida Center Training Institute, which is an evidence-based intervention used nationally. Assembly Bill 6 is mirrored after the Families Moving Forward program's eligibility criteria, which is tailored for children ages 3 to 13 with FASD who exhibit behavioral challenges and their families. This age range reflects the critical development periods where early intervention can have the greatest impact. produce lasting change, and to maximize the impact of resources on children and their families. Other services such as vocational rehabilitation, VR, are available after the age of 14. Currently, individuals with FASD can apply for services through the regional centers. However, those individuals are required to meet substantial limitations to be eligible for those services. Assembly Bill 6 will provide opportunities for those children with FASD and their families who don't meet substantial limitations to access service coordination, resources, and supportive services. Assembly Bill 6 will provide the department an additional support to children with FASD and their families. In closing, we want to thank the committee for the opportunity to present Assembly Bill 6, and we are happy to answer any questions.
Thank you. I believe we have a few questions, so we're going to start with Assembly Member Dahlia.
Thank you, Chair, and thank you for your presentation. I have a quick question about some of the language. So if I could turn to Section 1, Item 2, I see this enumerated list is contingent on to the extent funding is available. In the event the program isn't fully funded, are there items among this list that are going to be the priorities? Thank you.
Thank you for the question. Ricky Robb for the record. At this point in time, there is not a fiscal note attached to Assembly Bill 6, and for that reason, it is to where we can get started. The training that we've done through the FMF model is to actually create and build our provider capacity. As of right now, Nevada does not have any providers who are able to provide appropriate care for children who are diagnosed with fetal alcohol syndrome disorder.
Thank you. Assemblymember Nguyen.
Thank you, Chair, and thank you for the presentation. I just want to see if you can go back. I think you touched on it for a little bit, but why do we cap it at 13? And then what happens after that? You mentioned something separately, so if you could recap that for us, that'd be great. Thank you.
Thank you for the question. Ricky Robb for the record. I'm going to introduce Samantha Jaime, and she'll be able to proceed with your question.
Thank you for the question, Samantha Jaime for the record. During the pilot program, our team worked with the Families Moving Forward program, which is an FASD intervention used nationally with the Training Florida Institute. The age range reflects the critical development periods where early interventions can have the greatest impact. Research show it's critical window for neurodevelopmental and behavioral interventions to produce lasting change. And we want to ensure that with the proven research to maximize the impact and resources of children and families. We also want to work towards provider capacity and the lessons that we've learned with ATAP on building our provider network. There are other programs in place, such as vocational rehab, that we would work closely with and already do through the Autism Treatment Assistance Program for transition.
Quick follow-up, Chair. So just want to clarify what you said earlier as well, is that right now it's just, we're just going to kind of create it from scratch. So as of currently, ATAP does not have the adequate resources from day one.
Ricky Robb for the record. That is correct. So currently, the Autism Treatment Assistance Program is strictly for children who are diagnosed with autism. And so this enabling language would allow us to work with children who have a diagnosis of fetal alcohol syndrome. Mm-hmm.
Thank you. Next, we have Assemblymember Koenig.
Thank you, Chair. So by not having any fiscal bill attached to this, where's the funding going to come from to support this program?
Thank you for the question, Ricky Robb for the record. Well, what we have found is that when we start these programs, we want to build that infrastructure. We look for training opportunities with current providers. And so the training that we were able to receive was through the alcohol tax, through the public and behavioral health funding. And so we will continue to find that. We will probably be back at this next legislative session, not this current, in the 28-29 legislative session to make a request for actual funding when we have the data and the feedback that we need.
Thank you for for that answer, and I think, yeah, if you come back with a program that's up and running, then it's more likely to want to fund it, so thank you.
Thank you. Next up, we have Assemblymember Goulding.
Thank you, Chair. I'm a little confused about the pilot program. So during the pilot program, was that just staffing training, or were there any participants involved?
Thank you for the question, Samantha Jaime, for the record. During the pilot program in the last 2 years, we've had a lot of lessons learned. We've been working with members of the community for referral sources, too, to make sure we know who in the community is eligible and would need these services. We also did focus primarily on our staffing training, so we did work with the Florida Institute as well as Seattle Children's to get trained in the families moving forward. We also worked with the FACETS training, which is the Fetal Alcohol Spectrum Consultation, Education, and Training Services. So we were able to train our clinical program planner and our psychological development counselor, who would be the cornerstone of this program and building it. We worked with FASD United locally as well as in Seattle too. And then we've been working with our current provider network to see who is serving this population, who is interested in serving this population, and who would like more training to do so. And so that's been primarily where our pilot has gone. We have also identified some youth currently on the ATAP program that have co-occurring autism as well as FASD, and have been meeting with some of those families as well to start the program.
Thank you. Assemblymember Gonzalez.
Thank you, and thank you for the presentation today. My question is, can you speak to when a child would get diagnosed with this? Like what age group?
Great question. Ricky Robb for the record. So I think the challenge is that we could have a child who tests positive at birth, and so they would have that documentation early on, but we have many children who are not diagnosed early on based on admission or lack thereof admission of the parent. So a lot of times we see these children later diagnostics, and that is a challenge because we have to be able to find the medical documentation that goes along with it. So typically we don't see behaviors and things like that in at the early ages. It's usually between 4, 7, 9 when we see the behavior changes. Many of them are misdiagnosed with autism or other behavioral diagnostics, but unfortunately that's where we want to be able to make sure we're providing them adequate and appropriate services, because what may work for a child with autism probably won't work for a child with fetal alcohol syndrome disorder.
Thank you. And then I just had a follow-up question. So if you said that at birth they test positive, does that mean that they automatically have this diagnosis, or is there something that presents them to then make this diagnosis? Thank you.
Ricky Robb for the record. No, it does not automatically. There's many things that go into diagnosing a child with fetal alcohol syndrome disorder, and that's just one of many. We utilize a multidisciplinary team, an MDT team, who actually would do the full facilitation and determine if that child has it. Again, like for developmental services, they have a team that they work with for youth, and then there's a small group in Nevada who are currently diagnosing, but that's one of the things that we actually need to increase on the capacity.
Next is Assemblymember Gray.
Thank you, Madam Chair. Thank you guys for the presentation. Is it your intent to capture, I mean, I've heard syndrome, I've heard spectrum. What about fetal alcohol exposure, where you've got kids that they don't present with physical characteristics or anything, and then ties into the other question where they, they develop, or the symptoms become apparent further down the road. It's just, it's one of those things that it may not manifest itself, or it may be obscured by another diagnosis. So just wondering.
Ricky Robb for the record. Unfortunately, that is part of the issue, is that if a child we don't have the knowledge at birth. We don't have the information until they start showing those behaviors, which is usually that 4 to 7 years of age. And so those are the children that we're hoping that we can capture prior to any of the juvenile justice situations or things like that because of the misdiagnosis. So our goal is to have providers who can do the assessments and to support those families with intervention as well as resources.
Thank you, Madam Chair. So this would encompass the exposure kids then that have some of the features, some of the some of the problems of fetal alcohol syndrome, but not necessarily present as a fetal alcohol syndrome kid.
Ricky Robb, for the record, I think the challenge is the diagnostics, which is a challenge that we have in Nevada, because at this point in time, based on the documentation that we need to have to truly diagnose that child, we can have all the characteristics that we have, and we see this a lot in children who have either been adopted or that are in the foster care system, is that we don't have that full medical record or that child was exposed. Because as we all know, with that we're learning more and more every year, when we have a child that has in utero exposure, their level is varying. And so the hope is that, yes, we would be able to, if we can get them formally diagnosed, and that we can be able to get them an appropriate diagnosis.
Thank you. Next question we have from Assemblymember Hafen.
Thank you, Madam Chair, and thank you both for being here today. I supported the pilot program last session. Think it was a good deal, a good idea to start looking into. But I've been sitting through Ways After Dark recently and listening to how we just don't have funds for X, Y, or Z, and now we're watching the federal government cut funding for subscriptions to Politico. And so I'm struggling here to see how there's a zero fiscal note on this, when last legislative session there was a $2.6 million fiscal note each year and a $1.3 million fiscal note for future bienniums. And I understand subsection 2 states that to the extent money is available, but I'm just concerned we're going to start a program where we don't have any money for it. A, how are we going to run a program without any money? And B, what is going to be how are we going to have long-term success if we're not going to fund a program and it's just going to sit on the books?
If I may, if you don't mind, first of all, it's not a money committee. I appreciate the question, Assemblymember Hafen. The youth that we're talking about may co-present and are not currently receiving services for an existing program. But with that, I'll let the division go ahead and respond to that money question.
Ricky Robb, for the record, I appreciate the question, knowing that this is not a money committee. However, how do we develop these programs? And I think one of the challenges, and so let me just back up a little bit, one of the challenges that we find is that sometimes we get funding to create a program, but provider capacity isn't there, so we can't expend that funding. So we have determined that through this FMF model, our hope is that if we can get these providers trained appropriately and we can build those capacities, we can come back to the money body to be able to say, we have X amount of children who are ready, and we have a number of providers who can actually provide these services. I think we find it very difficult sometimes. Is it the chicken or the egg, right? And so I understand your question, respect it, but I think in the same sense, we're trying to do our due diligence and have the information to bring to you so that we can tell you how much do we know we need based on the children and the provider capacity. Because we have had many programs, as I can say, I appreciate the shout out that Administrator Schmidt gave us, because ATAP was one of those. They had funding, but we did not have provider capacity. And so we had to flip that program to build provider capacity to be serving over 1,000 children today, when we used to have a wait list of 800 to 900 children, and we were only serving 200. So I think the lessons that we learned with Autism Treatment Assistance Program is let's build, at least get the building of the system together so that we can come back with a very educated fiscal amount. And then to your second question, Ricky Rob, for the record, on the long term, our belief is that we would be able to build a stronger system by being able to have that data and bring that to you. We are fully aware of what Nevada is looking at on our budgets, and so we want to make sure that we can bring you some data as well. So I hope that answers your question.
If I understand it correctly, we're going to build a plane, park it in the garage, and wait until we can afford jet fuel to fly the plane.
Ricky Rob, for the record, the goal is to build the plane and train the pilots at the same time so that when we have passengers, we can actually get off the ground.
Assemblymember Nadeem.
Thank you, Madam Chair. My question is, what are the symptoms of early childhood diagnostic? How do we know that this child is affected by the alcoholism?
Ricky Rob, for the record, the list is long, and I don't want to misspeak. I am not a physician. I'll be happy to bring that information back to you so that you have the full details. Again, that multidisciplinary team is vital in diagnosing a child or youth with fetal alcohol syndrome disorder because the list is long. And it could, yes, there's facial features and there's behaviors and there's things like that, but they also could be characterized in other disabilities and disorders as well. So we want to ensure that we have the appropriate team to be able to make that diagnosis. And that's why in most states, as well as Nevada, it is a multidisciplinary team where there's anywhere from 3 to 5 team members that are analyzing and looking at the medical records to ensure that we are making an appropriate diagnosis.
Thank you.
Thank you. I do believe those are all the questions from the committee. Thank you for your presentation. If you will step back, we will next hear testimony in support of Assembly Bill 6. Anyone in support, please come forward. You're also welcome to call in. We will check the line shortly. You may begin.
Good afternoon, Chair Brown-May and members of the committee. Allison Herzik, last name spelled Herzik, Director of Nevada Government Relations for Dignity Health St. Rose Dominican. I'm here today to testify in support of Assembly Bill 6 and this incredibly necessary program. We want to thank Deputy Administrator Rob and Ms. Jaime for their work on this and the Aging and Disability Services Division for bringing this bill forward. Thank you for your time.
Hello, dear Chair Brown-May and members of the Assembly HHS Committee. My name is Carissa Pierce, P-E-A-R-C-E, and I represent the Children's Advocacy Alliance as our Government Affairs Manager. The Children's Advocacy Alliance is an independent voice for Nevada's children, and we primarily work in children's education, children's health, and child welfare, and we achieve public policy wins through collaboration and collective impact with the community. Today I'm testifying in support of AB 6. This bill provides Aging and Disability Services Division the necessary oversight to create an essential program, effective and thoughtful treatment program for children living with FASDs. The FASD Treatment Assistance Program will provide a necessary roadmap for families navigating treatment and what happens after treatment. And early intervention is essential for shaping the future of youth with developmental delays by improving developmental trajectory. Thank you for your consideration, and we ask that you please consider passing AB 6.
Chair, members of the committee, Jonathan Norman with the Nevada Coalition of Legal Service Providers. Within the Legal Service Providers Legal Aid Center of Southern Nevada and Northern Nevada Legal Aid represent about 4,000 kids in foster care in the state. The number of kids who have diagnoses of FASD or have not had an appropriate diagnosis and need treatment is tremendous, and it's kind of a we get them treatment or they're on their a path to be expelled from school. They're on a path to get juvenile justice citations and ultimately, I believe, enter the adult carceral system. So I can't stress how important it is to support a program like this that brings these services to some kids who really, really desperately need it. So thank you for your consideration.
Thank you. Anyone else up here in Carson City in support of Assembly Bill 6? Seeing none, we'll move down to Las Vegas. Anyone in support in Las Vegas? No one is moving there. AVH, is there anyone online in support of Assembly Bill 6?
If you would like to testify in support of Assembly Bill 6, please press star 9 or raise hand in your Zoom window now to take your place in the queue. You may begin.
Good afternoon, Chair Brown-May and Vice Chair Nguyen and members of the committee. My name is Rebecca Acosta, and I respectfully submit my support for AB 6 to establish a fetal alcohol spectrum disorder treatment assistance program. As a pediatric health advocate, I'm regularly contacted by families who are searching for resources for under-supported diagnosis like FASD. These families are desperate for support, from necessary medical services, emotional support, and of course, assistance in covering all of the associated costs of evaluation and treatment. A diagnosis like FASD affects the child and their entire family and is largely unknown amongst the general public. It's a lifelong condition, and effective intervention is dependent on available medical services, a family's ability to navigate our fragmented system, and their ability to afford such care. The Fetal Alcohol Spectrum Disorder Treatment Assistance Program will provide a home for these families living with FASD diagnoses. They will receive evidence-based information, evaluation, and treatment options. Families will have the support of trained professionals to address the extensive needs of the patients. With this early and continued intervention, youth with FASD diagnoses have a better chance of avoiding inappropriate placements and the juvenile justice system. This critical service will lift up children and families who have largely been forgotten in our community. I urge you to make the right choice for Nevadans and pass AB 6. Thank you for your time today.
If you have recently joined and would like to testify in support of Assembly Bill 6, please press star 9 or raise hand in your Zoom window now. Chair, the line is open and working. There are no other callers to testify in support at this time.
Thank you. Next, we'll move into opposition. Anyone who is in opposition of Assembly Bill 6 may please step forward here in Carson City or in Las Vegas. Seeing none, AVH, is there anyone on the telephone line in opposition?
If you would like to testify in opposition to Assembly Bill 6, please press star 9 or raise hand in your Zoom window now to take your place in the queue. Chair, there are no callers choosing to testify in opposition at this time.
Thank you. Now we'll move into neutral testimony. Anyone here in neutral on Assembly Bill 6, please come forward in Carson City or in Las Vegas. Seeing no one moving in Las Vegas. Anyone on the telephone line in neutral?
If you would like to testify in neutral for Assembly Bill 6, please press star 9 or raise hand in your Zoom window now to take your place in the queue. Chair, there are no callers wishing to testify in neutral at this time.
Thank you very much. As the presenter, do you have any closing comments that you'd like to make before we close the hearing?
Ricky Robb for the record. I just want to thank you, Madam Chair, and members of the committee for allowing us to present today. We really believe that this is just the first step of many and a long road ahead of us to ensure that we are supporting children and families with that diagnosis and providing true support and services and intervention. We're lacking that in Nevada, and it would be my great pleasure to be able to take this to the next level and to support these children and families. Many of these kids are unexpected blessings to families who adopt them, who give birth to them, and we just want to be able to support them overall. So thank you for the opportunity.
Thank you for your presentation today. With that, we will close the hearing for Assembly Bill 6. That moves us to our next item on the agenda, public comment. So I will now open up time for public comment. As a reminder, each person has 2 minutes to provide testimony. Public comment may be submitted to the committee up to 24 hours after any hearing. Is there anyone here who would like to offer public comment today here in Carson City, in Las Vegas? Seeing none, anyone on the telephone line, AVH, to offer public comment today?
If you would like to provide public comment, please press star 9 now to take your place in the queue. You are unmuted and may begin.
Hi, my name is Alyssa Dennison Glasgow, and I am with Olive Crest, a nonprofit working to end child abuse and neglect by addressing the root causes. We're working on doing this through a couple of different pathways. First, family preservation. How do we strengthen families so kids are safe and they don't need to be removed into the child welfare system? How do we keep them home and safe? The second pathway is through licensed foster care, providing safe and loving homes to kids who are in foster care and providing training for those who care for them. The third is equipping teens and young adults for life after a life they dream that after they age out of the foster care system. We teach them independent living skills. So we're seeing a lot of issues here in Las Vegas, but some of the main specific issues we're seeing are differential response in family resource center contracts. They're covering the same service areas, but they don't align. What we'd like to see is them to be able to better align to serve areas and better support families of origin and foster families with resources. So that way we can prevent them from entering the child welfare system. So that way we can bolster support for foster families and bio families to ensure greater longevity. The second issue is private agencies, foster agencies. We see an influx of people or kids at Child Haven. So one of the things we'd like to work on is private agencies being receiving centers and being able to license their own families. If they can be receiving centers, then we can receive children in homes before they go to their long-term foster homes, instead of them going to Child Haven and spending weeks, months, and sometimes even years there. The third specific issue we'd like to talk about or address is more beds with programming for kids who have aged out of the foster care system. We're seeing a pop-up of more and more beds, but it doesn't come with life training, life skills. It's just essentially housing them until we think that they're okay. So those are some of the issues that we are working on and that we'd like to see addressed in the upcoming future.
Thank you for your comment. AVH, is there anyone else?
Chair, the public line is open and working. There are no other callers at this time.
Thank you. Members, any other comments before we close today's meeting? Thank you. Our next meeting will be Wednesday, the 12th of February, where we have 2 bill hearings scheduled, Assembly Bill 36 and Assembly Bill 42. With that, seeing no further business before us, this meeting is adjourned.